Imagine you're looking at, like, an X-ray of a broken arm. You see the dark space of the tissue, the bright white of the bone, and right there in the middle, just a jagged, unmistakable fracture.
Right. It's incredibly obvious.
Yeah, and there's a specific comfort in that, you know? It's visible, it's categorical. The doctor points to the screen and says, there's the problem. It honestly feels like engineering.
Oh, totally. It's entirely binary.
Right.
Like it's either broken or it's not broken. And to be honest, it's a highly satisfying way to practice medicine when the problem reveals itself so clearly on a screen.
Right, but if you're stepping into the world of clinical neurology, that comforting X-ray machine suddenly feels completely inadequate because you're looking at a diagnostic landscape that isn't binary at all. It's murky.
Extremely murky.
Right.
Because the problem often hides deep within these microscopic cellular pathways or, complex overlapping networks. It is the absolute definition of diagnostic muddy waters.
Yeah, and that's exactly what we're navigating in this deep dive today. We're working from this truly comprehensive stack of excerpts from the 6th edition of the Mayo Clinic Medical Neurosciences textbook.
Right, which is a fantastic resource.
It really is. And our mission today is highly specific. We want to equip you, whether you're a medical student, a young healthcare professional, or just a fiercely dedicated self-taught learner with the tools to become a true clinical detective.
Because neurology isn't just about memorizing where things are in the brain. It's about solving a high-stakes puzzle using the patient themselves as the ultimate laboratory model.
Exactly. So we're going to unpack the exact coordinate system that neurologists use to pinpoint where a problem is and what's causing it. But before we even touch the anatomy, we need to understand how to actually think about a clinical problem.
Yeah, that's really the foundation of the Mayo Clinic approach. The textbook outlines 2 primary ways a clinician attempts to solve a problem. The first is pattern recognition.
Okay, so like recognizing a familiar face.
Basically, yeah. This is what happens when a patient walks in and their presentation is absolutely identical to something you've seen 20 times before. You don't even really have to think. You just instantly recall the diagnosis.
Well, that's fast. But let me guess, it completely falls apart if the case is complex or if the patient, doesn't read the textbook and presents with something totally unfamiliar.
Precisely. Pattern recognition is incredibly fragile.
Mm.
If just one symptom is out of place, the whole pattern breaks and the clinician is left guessing.
Not ideal.
No, not at all. Which is why the Mayo Clinic framework relies on the second method, which is inductive reasoning. This is a logical step-by-step analysis where you trace a problem to its source based on the underlying structure and function of the nervous system.
Right. It relies on hypothesis testing.
Exactly. You gather your data from the patient, you form a hypothesis about what's broken, and then you actively look for physical evidence to prove or disprove it.
And to do that inductive reasoning, the text gives us this legendary framework called the basic 4 questions. Let's lay these out for everyone.
Go for it.
Okay, number 1, what is the level of the lesion? Number 2, what side of the nervous system is involved? Number 3, what is the temporal profile? Meaning, like, how fast did this happen?
Right.
And number 4, what is the most likely pathology or cause? And as I was reading this, it struck me that this whole diagnostic framework is exactly like a game of Battleship.
If we look at the mechanics of the game, that analogy actually holds up perfectly.
Think about it. When you play Battleship, you can't just guess randomly. First, you need the grid coordinates to know exactly where on the board you're aiming. That's questions 1 and 2, the level on the side. You have to locate the peg on the board.
Right, you need the spatial location.
But getting a hit isn't enough. Right. You then need to know what kind of ship you just struck. Is it a submarine? A destroyer? That's questions 3 and 4, the temporal profile and the pathology. You need the physical location and the identity of the culprit.
That's a great way to visualize it.
Yeah.
But to play this game of neurological battleship effectively, you first have to understand how the board is actually drawn. We need to define the axes of this grid, starting with the vertical axis.
The levels.
Right, the 4 horizontal levels of the neuraxis, going from top to bottom.
So if we're mapping the grid, the very top level is the supratentorial level. This includes the cerebral hemispheres and the diencephalon. I like to think of this as the high-rent district of the brain.
It really is.
We're talking about high-level functions here. Thinking, memory, emotion, vision, and conscious, voluntary movement.
Yeah. And then moving down the vertical axis, we hit the posterior fossa level. This houses the brainstem and the cerebellum. It is incredibly cramped real estate, but it's prime territory for the cranial nerves.
So what does that control?
This level controls eye movement, facial and throat functions like swallowing, as well as your auditory and vestibular systems for hearing and balance.
Okay, got it. Then we drop down into the spinal level, which contains the pathways running within the vertebral column. This level manages the neck, arm, chest, abdominal, and leg functions.
Exactly.
And finally, the lowest point on the vertical axis is the peripheral level. This is basically everything outside the central highway. The nerves reaching into your fingers and toes, the neuromuscular junctions where the nerve actually meets the muscle, and the muscles themselves.
So that's our vertical axis.
Hmm.
But to get a specific coordinate on our battleship grid, we need intersecting lines. Those are the 7 longitudinal systems running up and down through those vertical levels.
Okay, let's list those. We have the sensory system bringing information in, the motor system sending commands out, the autonomic system handling involuntary functions like your heart rate.
Plus the consciousness and emotion systems.
Right. And then there are the last two, the ventricular or cerebrospinal fluid system and the vascular system. But wait, I have a question about this.
Sarah, what is it?
If I'm looking at this as a grid of like electrical wires, the blood vessels and the fluid spaces don't actually transmit neurological signals, do they? So why are they listed right alongside the motor and sensory systems?
You've hit on a really crucial clinical distinction there. The first 5 you mentioned are indeed neural signaling systems. But the vascular and CSF systems are fundamentally different. They're what we call support systems.
Okay, so why are they on the main grid?
The reason they're plotted on this diagnostic grid is that diseases originating in these support systems always manifest as secondary alterations in the neural pathways they support.
Oh, I see.
Yeah, like a blocked blood vessel isn't a failure of a motor neuron itself, but it starves that motor neuron of oxygen, which then produces a motor deficit. You literally cannot diagnose a stroke without mapping the vascular support system.
That makes a ton of sense. The hardware fails because the power supply got cut. So how does this incredibly complex battleship board even form in the first place? Because the textbook spends like a significant amount of time diving into neuroembryology here.
It does, yeah. Because understanding how the board is built explains why certain diseases present the exact way they do. It all starts in the embryo with the formation of the neural tube.
Right.
As this flat sheet of cells rolls up into a tube, it differentiates. It forms layers, the ventricular, subventricular, and marginal zones. And then it splits into an all-R plate in the back, which handles sensory inputs, and a basal plate in the front, which handles motor outputs.
And there's one specific gene controlling this that honestly has the greatest name in all of biology, sonic hedgehog.
I know. The naming conventions of geneticists are quite something. But jokes aside, the sonic hedgehog gene is absolutely critical for a process called ventral induction.
What does that do?
It basically acts as a chemical signal telling the front part of the developing brain and face how to form, and most importantly, how to split into 2 distinct left and right hemispheres.
And if that gene misfires, the board is drawn incorrectly right from the start. The text points out that a failure here leads to a devastating condition called holoprosencephaly, where the brain just completely fails to divide.
Exactly. It's profound. And further down the grid, if that initial neural tube fails to zip up and close completely at the spinal level, you see defects like a myomeningeal.
Which is when neural structures literally bulge outward through an open defect in the lower spinal column, right?
Yes. The text actually presents a clinical problem about a newborn with a fluid-filled mass on her lower spine who's unable to move her legs. It's a stark reminder that this grid isn't just abstract geometry. It's a developmental marvel, and when the engineering fails early on, the neurological deficits are massive.
Which brings us right back to our diagnostic framework. We have our grid, we know how to find the location, the level, and the side. Now we need to figure out what kind of ship we've hit.
Right, moving to question 4.
Exactly. This is the transition to the fourth of our basic 4 questions, pathology. And the rule here is so fascinating to me. The speed at which symptoms appear is your biggest clue.
The temporal profile, the clock, dictates the culprit. If the onset of symptoms is acute, meaning they appear suddenly, evolving over minutes to days, we are almost always looking at a vascular event, like a hemorrhage or an infarction.
What about trauma, like a car crash?
Trauma is also acute, yes, but trauma typically announces itself with an obvious external cause, so it's usually easier to pinpoint.
Okay, so a sudden drop is a blood flow problem. What if the timeline is subacute, like taking days to weeks to develop?
A subacute timeline strongly points to an inflammatory or infectious process. It just takes time for bacteria to multiply, or for the body's immune system to mount a localized response. which is why you see that slower days to weeks progression in something like meningitis or a brain abscess.
Got it. And finally, chronic. This is a problem unfolding really slowly over months or even years. The text splits this into two specific categories.
Yes, it does.
If it's a focal problem, meaning it's slowly getting worse in one highly specific area of the grid, it suggests a neoplasm, like a tumor growing and pressing on surrounding tissue. But if it's a diffuse problem, slowly worsening across widespread areas of the brain or body, it suggests a degenerative disease like Parkinson's or Alzheimer's.
Perfect. But we must also account for metabolic or toxic disorders. These are the wild cards of the temporal profiles
Why are they wildcards?
because they often present with diffuse signs that don't perfectly obey a single timeline, which means they require systemic investigation, blood tests, checking liver function, looking at a patient's nutrition.
Okay, let me pause and actually try to use this logic. Let's say a patient comes in with an acute focal deficit.
Right.
They suddenly lost the ability to move their arm.
Okay.
But in scenario A, the paralysis hits its peak immediately and just stays there. It's non-progressive. But in scenario B, the paralysis starts acutely, but it's progressive. Like it gets worse hour by hour, spreading to the leg. Does that subtle difference in the clock change our vascular hypothesis?
That is an excellent application of the framework. Both scenarios are vascular events, yes. But the subtle difference in the timeline dictates the exact type of vascular catastrophe.
Oh, wow.
Yeah. As the source material outlines, an acute, focal, and non-progressive deficit strongly points to an ischemic infarction, a stroke. A clot has blocked a vessel. The downstream tissue is starved of oxygen immediately. The damage is done quickly, and the symptom just peaks.
But the progressive one?
An acute, focal, but progressive deficit suggests an expanding intraparenchymal hematoma.
A brain bleed.
Exactly. A blood vessel is ruptured inside the brain tissue. The bleeding is actively continuing, forming a pool of blood that slowly expands, pressing on more and more surrounding tissue, which is exactly why the symptoms get worse hour by hour.
Wow. So paying attention to the exact minute-by-minute timeline completely changes your diagnosis. But, to truly understand why a blocked vessel or an expanding pool of blood causes paralysis, we have to zoom way, way in. We need to leave the macroscopic grid and look at the actual electrical wires. We're talking about neurocytology, the cells themselves.
We must, because understanding how individual neurons and their supporting cells function and how they fail provides the biological why behind the clinical symptoms. We have quite a diverse cast of microscopic characters here.
Walk us through them.
Well, beyond the neurons themselves, we have the glial cells, which are basically the support staff. We have astrocytes, which maintain the chemical environment around the neurons, ependymal cells, which line the fluid-filled ventricles, and microglia, which act as the immune scavengers, cleaning up cellular debris.
And then we have the insulation crew, right? The cells that manufacture myelin. But there's a really strict division of labor depending on where you are on the grid.
Very strict.
In the central nervous system, so the brain and spinal cord myelin is made by oligodendrocytes. But out in the peripheral nervous system, it's made by Schwann cells.
Yes. And we need to be very clear about how this insulation actually works. Because myelin isn't just a rubber coating that keeps electricity from leaking out. It's spaced out. Imagine a long wire coated in thick beads of insulation, but between every single bead, there's a tiny exposed gap of bare wire.
The textbook calls the insulated bead the internode and the bare gap the node of Ranvier, right?
Exactly. When an electrical signal at action potential travels down the nerve, it doesn't flow smoothly like water in a pipe. It literally jumps from one bare node of Ranvier to the next bare node of Ranvier, completely skipping over the insulated internodes.
That sounds incredibly efficient.
It is. This jumping process is called saltatory conduction, and it allows the signal to travel incredibly fast.
So what happens when a disease attacks that myelin, when the insulation is just stripped away?
When the myelin is destroyed, the electrical signal can no longer jump. It has to painfully crawl along the now bare axon, leaking energy the whole way down. Physiologically, demyelination severely impairs the conduction velocity. The signal slows down or just stops completely.
That's devastating.
It really is. And that division of labor you mentioned earlier is clinically vital here. If a patient's immune system attacks the oligodendrocytes in the central nervous system, we're looking at multiple sclerosis.
But if the immune system attacks the Schwann cells in the periphery...
Then we're looking at something like Guillain-Barré syndrome. The textbook describes this as an acute inflammatory demyelinating polyradiculoneuropathy.
Let me just translate that for a second because that's a mouthful.
Hmm.
Polyradiculoneuropathy just means a widespread disease of the peripheral nerves and their roots, right?
Exactly. The immune system is stripping the insulation off the peripheral wires. So a patient with multiple sclerosis and a patient with Guillain-Barré might both complain of severe weakness. But because the cellular target is different, the clinical level on our battleship grid is entirely different.
That makes perfect sense. Now, diseases don't just attack the insulation. Sometimes they attack the actual connections between the wires. The text dives into the neurophysiology of ion channels, specifically highlighting this fascinating channelopathy called Lambert-Eaton myasthenic syndrome, or LEMS.
LEMS. It is a profound example of physiology dictating symptoms. In this disorder, the patient's own immune system produces antibodies that attack voltage-gated calcium channels on the presynaptic motor nerve terminal.
Okay, let's visualize this. Normally, when an electrical signal reaches the very end of a nerve, it needs to cross a gap to tell the muscle to flex, right?
Right, and to do that, calcium channels open, calcium rushes in, and that triggers the nerve to dump packets, or quanta, of a chemical messenger called acetylcholine into the gap.
But with LEMS, the antibodies are blocking those calcium channels. The signal arrives at the end of the wire, but the door just won't open. The calcium can't get in, so the chemical messenger isn't released. The text calls this a quantal release failure.
Which means the muscle doesn't get the message, and the patient experiences profound weakness.
But here's the part that totally blew my mind. With LEMS, the weakness actually improves if the patient forces themselves to keep using the muscle. Why on earth does exertion make it better?
Think of it like priming a rusty pump. With repeated, rapid stimulation, meaning the patient repeatedly trying to flex the muscle, the few calcium channels that are still working are forced to stay open longer. Calcium gradually builds up inside the nerve terminal until it finally forces enough of that chemical messenger out to trigger a muscle contraction. The physiology directly explains the clinical phenomenon.
It's just incredible. And we also see cellular failure where the cells just get clogged with garbage. Instead of attacking channels, neurodegenerative diseases create these toxic buildups.
Yeah, it's like an Alzheimer's disease.
Right. The text highlights two specific structural failures there. Inside the neuron, the structural scaffolding basically collapses, and hyperphosphorylated tau proteins twist together into what they call neurofibrillary tangles.
And meanwhile, outside the neuron, metabolic trash is piling up, with beta-amyloid peptides clumping together to form neuritic plaques. It's just a complete microscopic breakdown of the system.
Which brings us to the ultimate test of the clinician. We have the macro-level battleship grid, we have the clock indicating the pathology, and we understand the microscopic mechanisms. Now, we actually have to synthesize all of this.
Yes. Let's walk through some specific clinical rounds from the text and apply the basic four to see how inductive reasoning actually cracks a case.
Okay, I'm going to try and play detective here. Give me case number one.
All right. A 55-year-old woman presents with the abrupt onset of left-sided numbness and weakness. She's confused, and imaging shows clinical signs of brain swelling. Let's run the algorithm. Step 1, map the symptoms to the systems.
Okay, numbness means the sensory system is involved. Weakness means the motor system. Confusion points to the consciousness system. And the brain swelling implicates the ventricular and CSF support system.
Correct. Step 2 and 3. What is the level and what is the side? She has cognitive symptoms, the confusion, along with motor and sensory deficits.
The cognitive symptoms place the lesion high up at the supratentorial level in the cerebral hemispheres. And since her physical symptoms, the numbness and weakness, are on the left side of a body, the lesion must be on the left side of her brain, right?
Remember the wiring of the grid. The motor and sensory pathways cross over as they travel down the neuraxis. The left hemisphere controls the right side of the body, and the right hemisphere controls the left.
Oh, right. So if her symptoms are on the left side of her body, the focal lesion is actually on the right side of her brain. We're looking at a right supratentorial lesion.
Exactly. Step 4, the timeline in pathology. The onset was abrupt.
Okay, the clock tells us sudden onset is vascular. So if we combine an abrupt vascular timeline with a right supratentorial focal lesion and active brain swelling, we deduce that a vessel ruptured. This is a right intracerebral hemorrhage.
Look at that. The framework leads you directly to the reality of the pathology. Let's look at case 2.
Hit me.
An elderly retired oil tycoon is rushed to the emergency room. His symptoms? Severe abdominal cramping, pinpoint pupils, profuse salivation, and a dangerously slow pulse of 50 beats per minute. This all began exactly 30 minutes after eating a dinner of home-canned beans and mushrooms.
Okay, pinpoint pupils, profuse salivation, slow heart rate, and gastrointestinal cramping. These aren't motor or sensory issues, these are involuntary functions. They all trace back to massive overactivation of the autonomic nervous system. Specifically, the text notes this is excessive activation of muscarinic receptors.
Yes. And what does the temporal profile tell us?
It started 30 minutes after a meal, so it's highly acute. But the pathology isn't vascular here. Because it's tied to an ingestion, it's toxic. He's suffering from mushroom poisoning.
Right.
And because we understand the cellular mechanism that his muscarinic receptors are trapped in overdrive, we know exactly how to treat him. We give him atropine.
Precisely. Atropine is a muscarinic antagonist. It blocks the overloaded receptors and stabilizes the autonomic system. The inductive reasoning literally points right to the life-saving antidote.
Okay, give me one more.
Case 3. A 65-year-old woman with a history of very poor nutrition. Over the past 3 weeks, she has experienced a progressive decline in her ability to walk. Examination reveals a loss of joint position and vibration sense. You find a distinct vibratory sensory level at the C5 vertebra. Additionally, blood tests reveal she has macrocytic anemia.
Okay, let's trace the lines. Loss of position and vibration sense means the sensory system. The clear cutoff at C5 places this directly at the spinal level. But I need to push back on the timeline here.
Okay, why?
The timeline is 3 weeks. You told me earlier that 3 weeks is subacute, and subacute almost always means an infectious or inflammatory process. But the text says this is a metabolic pathology specifically, a severe vitamin B12 deficiency. Why did the clock lie to me?
The clock did not lie. It gave you a probability. This highlights a really critical nuance in the framework. Temporal profiles are incredibly strong statistical guides, but metabolic and toxic issues are the exceptions.
The wild cards.
Exactly. A nutritional deficiency can present subacutely or chronically, depending entirely on how fast the nutrient depletes from the body. This is why a clinical detective must always look for corroborating evidence.
Which is where the blood test comes in, the macrocytic anemia.
Yes. Macrocytic anemia means her red blood cells are unusually large and structurally immature because they literally lack the vitamin B12 necessary to divide properly during development. That piece of data, combined with her poor nutritional history, steers you away from an infection and correctly toward a metabolic B12 deficiency. You must weigh all the data points, not just follow the clock blindly.
That is a phenomenal reminder. The framework is a tool to organize your thinking, not a rigid script. We've covered a massive amount of ground today. We've armed you with the basic 4 questions: level, side, temporal profile, and pathology. We mapped the battleship grid from the supratentorial hemispheres all the way down to the peripheral nerves. And we explored how microscopic mechanisms like stripping the insulation off an axon or blocking a calcium channel create the physical symptoms we see in the clinic.
And mastering this approach takes an overwhelming, seemingly random list of patient complaints and transforms it into a logical, solvable puzzle.
Right.
It replaces panic with a systematic process. And to ensure this process has truly solidified for you, we want to leave you with a final, highly practical exercise directly inspired by the text.
Yes, listen closely to this because it has probably happened to you. Imagine you've been sitting in a lecture for 2 hours with your arm draped heavily over the hard back of a chair. You wake up, you lift your arm, and the back of your hand is completely numb and is just beginning to tingle.
We've all been there.
Exactly. So, using the inductive reasoning you learned today, try to answer these 2 questions. First, what is the level of the lesion? And second, physiologically speaking, is that tingling caused by hyperpolarization of the internode, or is it caused by partial axonal depolarization of the node of Ranvier?
Well, if you've been following the framework, the answers should materialize. The level is peripheral. You have physically compressed a nerve outside the spinal cord. And the physiological mechanism behind that tingling, the why, is the partial axonal depolarization of the node of Ranvier.
Yeah.
The physical pressure on the nerve caused a temporary loss of blood flow, which irritated those bare gaps where the electrical signal jumps, causing them to misfire and send tingling signals to your brain.
You just diagnosed yourself using inductive reasoning.
Indeed you did. And as we conclude, I want to leave you with a rather profound thought from the preface of the Mayo Clinic text. We spend so much time discussing incredible modern technology. Advanced functional MRI scans, genetic sequencing of the sonic hedgehog gene, molecular channelopathies.
We do, yeah, because it feels like that's where the real answers are.
But the authors make a point to remind us that despite all of our modern breakthroughs, the most advanced, sensitive laboratory model in all of neuroscience remains the patient themselves.
Wow.
The systematic history and the physical examination are not archaic traditions that we just haven't phased out yet. They were the ultimate act of translational medicine. The answers to the puzzle are almost always there, residing within the patient's own body, just waiting for a clinician who knows how to ask the right questions.
The murky waters really aren't so murky when you have the right map. Keep asking the right questions, and we'll see you on the next deep dive.